Rory, thank you. I'm conscious that I'm supposed to be chair and respondent. I was going to say, and certainly so far some people have responded and others have just chaired, so it just leaves me slightly open. I'm just going to make a few comments while I've got the power to do so. I winced when you mentioned the consent or anonymise, because that ran back to a report we did for the Department of Health in about 2001, and I've been trying to backtrack on that ever since. I'm sort of desperately hoping there's a historian in the House who can say, no, fortunately somebody else said it first and it's not all my fault, but it might be. I liked also your comment about authorisation, because that tied through with a paper I did with Michael Wadsworth, I think about 2005, 2006 in the BMJ, where we tried to look at the relative costs of express consent, opt-out, anonymisation, or what we called social consent, which was trying to say, could you have somebody that consented on behalf of society? And looking at how that scaled between small studies and large ones. It was, I'm afraid, very much a sort of a back-of-an-envelope thought experiment, so it wasn't based on hard evidence or anything, but I thought it teased out what would or wouldn't be practical when you got to large-scale investigations. Care.data, I think if we go there, we'll be lost forever. But I mean, it's going to be an interesting case. I think it was a bit unfairly picked on, but it's a case. It's a warning sign of what can happen when things go wrong and you don't communicate correctly. I thought tying in with some elements that Paula mentioned yesterday about the problems of realms of control, and I think Jonathan Sellers also touched on it about. You may think you've got consent, but I, as a separate data controller, do I believe you've got consent? How does your consent tie in with the consent I've got? And even if I do believe you and I think it's valid, do I care? Am I just going to go for, if you like, the caution and play safe? I won't do anything. And I think that's where, again, some of the authorization and social consent have a mechanism that, if you can like move it to adjudication between bodies, I think would be quite a useful one, particularly for this sort of large scale. I think the other thing that sort of snuck in there that I was really pleased to see was the linkage with patients, about getting patient-reported outcome measures, because I think that's one of the really big things that's missing across knowing what happens is how does it affect patients at the end of the day. Even with things, I forget who mentioned it, about getting employment data in, just absenteeism is actually a very useful measure, and I think it's a resource that's probably very little used in commerce, yet alone in healthcare. So anyway, those are a few words from me, but very interesting topics. Questions from the floor? Okay. So first hand up, even before the starter's gun went, was the gentleman from the HRA at the back. So, and then Bart and then here.
Hello, it's Will from the HRA. Thought I'd better give a bit of an update on how we're going to promote the use of data in research. There are a number of issues around this which were very well highlighted. One being that there's already a mechanism for this. We can release identifiable data without consent for research purposes. There is a mechanism for this, and the problem that we're having with this is that assurance from the Secretary of State to data controllers is an assurance. And the data controllers are doing as they please with that. And, you know, some are saying that's absolutely fine, and others are saying that's not fine. And so what we are doing is we've set up a working group that's being led by the confidentiality advisory group. And what we're engaging with data controllers, whether that be primary or secondary care, or we're interacting with the public and participants. And what we're asking is, how can we provide assurance to you? Because we already are providing assurance, but we're obviously not providing it in the right way. So what information do you require for us to give you assurance that this is fine? And so we are engaging with people on that. I think, again, it comes down to a lot of technical and logistical issues. So, and a lot of this will have to be with very, very robust IT systems. And if we are going to build up the trust of the patients and the public and the data controllers, we will need to be running a very, very tight ship to make sure that the data that we are providing is in line with consent or not, as and presented in such ways that are legal. One thing that I found incredibly interesting was the Estonian model that we saw yesterday. And, well, it was just interesting and nice to see that it can work. I think that one thing that will help is, as much as in the CARE Act that the HRA has it has to promote the use of data. Also, I think on the back of that is that people who wish to undertake research have to have due regard for HRA approval. And so on the other side, again, it's mandated in law that people do have to have due regard for our assurance. But what that assurance looks like, that is what we're trying to establish. It's the trust that we're trying to establish with the data controllers and the public. So as much as saying we've started work on it and that we have a working group and that if anybody would like to provide any feedback to us, we do welcome it. We are aware of the issues and we are addressing them as best we can.
Okay, well, thank you. Barton.
I'd like to address two legal questions to my legal colleague. Slightly controversial, but you know me for a long time, Graham. One is this coding, anonymization, de-identification issue and the need to use international language, or at least establish a concordance of similar terms like pseudo-anonymize under the directive means coding. We're talking linkage, so necessarily coded data or linkable data. Anonymization usually is irreversibly delinked. And so anonymized data is good for aggregate, open access, aggregate, and so on. If you code and then you recode before a secondary researcher gets it, and the secondary researcher by contract says, I will not do this, and someone else holds the key, not even the biobank, but there's a key holder, a trusted third party. My first question, is that secondary researcher working with anonymized data and therefore not subject to personal data legislation because there's no person, it's anonymized? Second question, on this issue of consent in biobank populations, where they consent to their health administrative data being accessed, or even further, to their medical records being accessed. In law, if you need consent, you either obtain it, or in the absence of consent, there's a legal provision that allows you to use data because it's legally mandated. So if there is consent, why doesn't someone take a mandamus or some legal action against the authorities who are illegally controlling, in quotes, their data to which they have consented that it be made available to researchers?
Thank you, Barton. So my answer to your second question, the slight glib answer is because we're not as litigious in the UK as you are in North America. But also, I mean, if we look at the example of UK Biobank, it has blown apart the notion of what does consent mean. And the reason why the draft data protection regulation is causing so much anxiety is because it's trying to sort of ossify a particular view of consent, which we know is actually not the reality. So and also in practical terms, even if you get consent, you look at the role of something like the Ethics and Governance Council, it's a broad consent. It's relative to what UK Biobank promised in the Ethics and Governance Framework. Depending on what the linkages are, there's always the question of, well, is that reasonably, where's Roger, reasonably within the remit of the consent that was given? All those questions reveal a vagueness and questions and issues that have to be addressed. So it's not, I think, as black and white as simply because there is consent, therefore, tick, we've got that. Yeah.
It actually says, I agree, on the last page to give access to my health administrative data. So it's not hidden somewhere, it's there.
Yeah, absolutely. But then, again, depending on what the researchers want to do, there'll be grey areas at the edges of that. And your first point about anonymization, while as many people in this room have pointed out very clearly, it's an art, it's not science. It's a vague notion. So legalistically, yes, so long as you do enough to anonymize the data, you will probably fall outside the realms of, in Europe, the data protection legislation. But of course, that legislation also points out that if you then receive data and you hold other data and it's possible to link up again, they can become, again, once more, personal data, and therefore you can become a data controller. So I think that's also a driver for concern and caution as well, because it's not even clear who becomes a data controller when with respect to which data. Even if you access them in an anonymized form, they can become re-identified.
I think there are also technical questions about whether it's assured identification or there's a chance in a large data set one strange, peculiar combination may come through. So this is where you get into the whole question of, is it a record is anonymized or is it a record set that's anonymized? And that leads to all sorts of vagueness, but politicians don't tend to like that sort of detail. But sorry.
I have a question to Dr. Collins. So you are receiving data from primary care providers and hospitals. How do you also receive text files? And how do you deal with the text?
Yeah, at the moment, all we're getting is coded data from the death, cancer, and hospitalization. The primary care is coded data also, so we're not typically seeking text data at that early stage of identification or ascertainment. In the next stages, and in the pilot work we're doing, we're then looking to see what additional data is most valuable and also most scalable, because you could get a lot of text data. It could be really quite a unscalable approach for a study like this. So we're looking to see what's the easiest way of getting as far as we can towards not only ascertainment but also adjudication, using the simplest forms of data in terms of coded data.
We are receiving hospital discharge records, which are very rich in data, but very hard to read.
Yeah.
If it's any help, I was involved in a MRC-funded study called CLEF that was taking cancer hospital records, not beautifully structured as one might like, but just letters, and trying to use natural language processing to extract stuff out. And I think it certainly proved that getting meaningful data out of it was harder than one realized. But it was also actually quite hard to get rid of all the bits that you wanted that might reveal something about an individual. Someone who had a flail leg and worked in a London car park could in theory be discovered, even though it didn't seem particularly meaningful. We did have one instance where we were desperately anonymizing doctors' letters for medical students to look at in terms of how they would interpret the data. And we left in somebody's professional qualifications, which turned out to be a unique combination about so long. And so in theory, you could re-identify the professional. So again, data protection law came into. Certainly, I think Biobank's wise to say, if it's free text data, just avoid it if you can. I mean, it's a nightmare.
I think it's also important to I mean, although it seems a very simple thing, the issue of false positives and false negatives is really quite critical to the strategy. We're not treating individuals. So if you were treating individuals, it really matters if you miss something. But from our point of view, we're not treating individuals. We're trying to produce a reliable database. And there we want to be reasonably sure that the people have got the disease, because if we have a lot of false positives, that can have effect on power. If we miss some, then that doesn't actually have that much effect on power. And so that really is quite critical to the strategy one would adopt in a large-scale study.
Yeah, that's true. Soren, we'd better make this, I think, the last question.
Soren Holm from the EGC. My question, I think, is primarily to Laurie, because you started talking about linkage to things that people would not necessarily think of as health-related. Now, epidemiologists would think of them as health-related, but most other people wouldn't. And I think that creates a problem sort of on the consent form, because, well, in the UK Biobank, the consent is to my medical and other health-related records. In other biobanks, you will find similar wordings. But clearly, they have to be construed as the participants understand them, not as we do. So pension records, educational records, the other things. I can see absenteeism. sort of just about getting in there, and my school nurse's records on me, but not my university degree records.
Yeah, I mean, so I was focusing on the follow-up of health outcomes. And so there I think the issue is more limited because what we're talking about are those kinds of linkages that either identify a potential health outcome or allow us to classify it more reliably. So I think in the main there's not an issue. With respect to linkages that primarily would be about exposures, trying to understand more about the environment, lifestyle, however you want to define it, of the participants. I agree it's much less clear. We tried to give some examples when we, in the information material, about what we meant by health-related. And I think this would be an example where one could look to other studies like ALSPAC, where they have had some experience of doing such linkages and understanding people's perceptions of those linkages. And I think it's also another area where, as Andrew Traherne said, and that we've been discussing with the Ethics and Governance Council, when we are engaged in things which you maybe do stretch the consent, if you like, or are not clear in the consent, that's a good opportunity for us to tell participants that these are the things we're thinking about and to get their views on it. So rather than kind of consulting all the time, but actually consulting on specific questions and getting the views of the participants as to whether they see issues with this, what their views are of these kinds of issues, and that would be one.
No, I think, well, given lunches there, unless everyone wants to keep... No, I think it's getting cold, so I think we'd better move on. But before we do, if we could thank the panel for that.